Thank you, Wayne. Well, it's clear that protein's very, very important, and also that more work needs to be done. Our next speaker is Denise Houston from Wake Forest School of Medicine, and Denise is going to talk more about vitamin D and physical function.
Good morning, and I'd first like to thank the organizers for inviting me to come and talk about this topic. And I'm going to primarily focus on physical function, although I think most of us have heard about vitamin D's effects on a lot of other health outcomes. So it has long been recognized that vitamin D plays an important role in intestinal calcium and phosphorus absorption, as well as skeletal health. Over the past 2 decades, a number of studies have shown vitamin D is associated with an assortment of different outcomes, and many of these are prevalent in older adults. Things like depression, cognitive impairment, high blood pressure, cardiovascular disease, diabetes, muscle weakness, osteoporosis, and osteoarthritis, as well as some cancers. However, the majority of these health outcomes have been observed in observational studies, with the exception of osteoporosis and skeletal health. In 2010, the IOM released the new dietary reference intakes for vitamin D and set the RDA based on a serum 25-hydroxy vitamin D concentration of 20 nanograms per milliliter, as that was the amount, and the RDA was set at either 600 or 800 for adults and older adults, as that was the amount of vitamin D needed to reach that 20 nanograms per milliliter. Those data were based on bone outcomes, as that was what the committee came to conclude were where the data currently exists from randomized controlled studies. Other health outcomes really have not had many randomized control studies, so there just wasn't sufficient evidence to suggest that maybe other intakes should be necessary for those outcomes. However, many observational studies have shown that possibly 30, maybe even 40 nanograms per milliliter might be optimal for other conditions, cardiovascular disease, cancer, even physical function. So there is this controversy about whether this cut point of 20 is actually sufficient for non-bone health outcomes. So looking at this pie chart, we see the current prevalence of vitamin D deficiency and insufficiency among older adults in the United States. Using the IOM cut point of 20 nanograms per milliliter, we see that about a third of older adults have vitamin D concentrations that are either insufficient or deficient. However, if it turns out that potentially higher amounts of 25-hydroxy vitamin D are needed for non-skeletal outcomes, an additional 50% of older adults may be at risk for vitamin D insufficiency. So this is a large number of the population that could be potentially at risk. However, we currently don't have the data from randomized controlled trials to establish whether higher amounts are actually needed. So as was noted earlier, there are some risk factors for vitamin D deficiency and insufficiency that are specific to older adults as well as common among the population. Decreased exposure to sunlight, this is especially a problem in homebound and institutionalized older adults. The decreased capacity of the skin to produce vitamin D, studies show that compared to younger adults, older adults produce about a quarter of the amount of vitamin D with the same exposure to UVB light. And then inadequate dietary intake is common among all adults, and this is primarily because vitamin D is found naturally in very few foods, with fortified foods, in particular milk, being the major food sources in the US. So this is the most recent data on vitamin D intake coming out of the NHANES 2005-2006 waves. The bottom yellow bars here show the amount of vitamin D coming from diet or food sources. The purplish bars in the middle are the amount of vitamin D coming from supplements, and the gray shaded area of the bar is the RDA shortfall. And so what we see in both men and women and across the adult age categories, approximately 200 IUs a day of vitamin D is coming from the diet. We do see an increase in vitamin D coming from supplements among the older age groups, but in part because of the higher RDA in those above 70, only about half of older adults are actually meeting the RDA from both diet and supplements combined. So what are the potential roles of vitamin D on physical function? Vitamin D has been shown to have both direct effects on muscle function as well as indirect effects. Some of those direct effects include effects on muscle contraction, muscle cell proliferation and differentiation, and muscle growth, with some studies suggesting that vitamin D may actually increase specifically the type 2 muscle fibers, which may be the reason for the association between vitamin D and fall risk. As far as some of the indirect pathways, neuromodulation, as we saw earlier, vitamin D has been shown to be associated with cognitive function, in particular executive function. Cognitive function, and in particular executive function, has also been shown to be associated with physical function. Inflammation, vitamin D has been shown to play a role in the inflammatory response by inhibiting the production of inflammatory cytokines, particularly IL-6 and TNF-alpha. Those inflammatory cytokines have also been shown to be associated with poor physical function and increased risk of functional decline. And vitamin D has also been associated with many of the same chronic conditions that are related to the development of functional limitations. Things like diabetes, heart disease, hypertension, osteoarthritis. So are 25-hydroxy-D concentrations sufficient to maintain bone health, adequate for optimal physical function in older adults? One of the largest original studies to come out looking at this was using data from NHANES 3. And showed that older adults with lower 25-hydroxy-D concentrations had slower walk speeds and sit-to-stand times. And here I've noted where the 20 nanograms is on both of these charts. And you can see that most of the difference comes at a range below the 20 nanogram per milliliter cut point. Our group has looked at this association in several cohorts of older adults, and I'm showing a couple of different examples. Here's data from the Health ABC study, which included both black and white men and women aged 70 to 79 at baseline. And what we see here is that older adults with low 25-hydroxy-D concentrations had lower physical performance on a physical performance battery that includes tasks of balance, a short walk test, and repeated chair stands, and also on different distances of walking. Here I show the 400-meter walk. What is also important to note is there appears to be kind of a dose response here, where we're looking at categories of less than 20 in the black bar, 20 to 30 in the gray bar, and 30 and above in the gold bar, suggesting that there might actually be an advantage of having higher 25-hydroxy-D levels for physical function. Here's some of our data from the CHS All-Stars. These are the exceptional survivors from the cardiovascular health study. So their average age was 85. And similar to other studies, they show an association between 25-hydroxy vitamin D concentrations and weaker grip strength, but not leg strength. And that has been observed in other observational studies where it's mainly the grip strength where there's an association. But again, we see somewhat of a dose response effect here, suggesting that maybe higher concentrations above 20 might be optimal for function. So one of the questions is whether or not there's a 25-hydroxy-D concentration threshold for physical function. It's been suggested that a concentration of 30 to 32 nanograms per milliliter is optimal for various health outcomes, including physical function. The early data from NHANES 3 showed that most of the increase in walk speed and sit-to-stand time occurred in individuals with 25-hydroxy-D concentrations between 9 and 16 nanograms per milliliter, so well below the 20 nanogram cut point that IOM used to set the RDA. More recent studies have formally tested thresholds and have found that thresholds might be higher for 25-hydroxy vitamin D concentrations and function. So this is data from Sol and colleagues using several cohorts out of the Netherlands. And what they found is that there was a threshold for the short physical performance battery, which again includes tests of balance, short walk speed, short walk distance, and repeated chair stands. And here they found a threshold of 26 nanograms per milliliter. So again, above the IOM cut point. They saw similar results looking at grip strength. We formally tested this using the Health ABC cohort, and here what we did is use piecewise regression models to see whether there was a difference in the association between the 25-hydroxyvitamin D levels and different performance measures, and at what point the slopes of those lines differed. So what we have here are the thresholds, and they range from 26 nanograms per milliliter and for grip strength up to 33 for the shorter gait speed measure. And what we saw is that at concentrations below this threshold, there was a significant and positive association between 25-hydroxyvitamin D levels and these performance measures. However, above these concentrations, there was no association between 25-hydroxyvitamin D and the physical performance and strength measures, suggesting that there'd be no benefit of having higher 25-hydroxyvitamin D levels. And again, we saw no association with the knee extensor strength. So this would suggest that data from both Health ABC and other studies that the 25-hydroxy concentration threshold for physical performance and muscle strength is likely between 24 and 32 nanograms per milliliter, so above the current cut point of 20. So are low 25-hydroxy-D concentrations associated with greater declines in physical function in older adults? And again, I'm going to show you a couple different examples of this. And what we see, and this is, I think, where a lot of the conclusions from the IOM committee came from, is that longitudinal studies are mixed, showing both no effects of 25-hydroxy-D concentrations on decline in function, as well as greater declines in both muscle strength and physical performance. So here's some of our data from Health ABC. What we have here is the black line being those less than 20, the gray line being the 20 to 30 group, and the gold line being above 30. And at every time point, those with lower vitamin D levels had worse performance, both on the physical performance battery as well as on measures of gait speed. But what you'll notice here is that the slopes of the decline are similar and parallel across all three concentrations, so there wasn't a difference in the rate of decline among those with lower 25-hydroxy-D concentrations. In contrast, data from the Rancho Bernardo study showed that women in the lowest quartile of 25-hydroxyvitamin D concentration had almost a twofold greater decline in physical function, and here they were using the timed chair stands and timed up and go measures. I will note that this is, the lowest quartile started at less than 32, which is a very replete vitamin D population here. So what are some explanations for these inconsistent results that we've observed in observational studies? First, differences in study populations, measuring this in people who are at risk for 25-hydroxyvitamin D deficiency and insufficiency versus those who are replete. Their baseline functional status, perhaps we're measuring it in populations who have such low function that it wouldn't matter what we did, we're not going to see any difference in their functional status. We've seen differences within the same cohort and across cohorts between men and women, in young old versus old, and among cohorts in the US as well as Europe. Also, different assays have been used to measure serum 25-hydroxy-D, and this has led to discrepant results. And until recently, there wasn't a standard reference measure in which to validate these results. Different cut points have been used to define 25-hydroxyvitamin D deficiency and insufficiency, some using more clinically relevant cut points like 20 or 30 nanograms per milliliter, others just using the population distribution. Also, different studies use different measures of physical performance, and different studies adjust for potential confounders or don't adjust for potential confounders, and in particular, not adjusting for things such as season, when vitamin D was measured, BMI, and physical activity, all which play a role in vitamin D, but BMI and physical activity are also risk factors for declines in physical function. And then also differences in duration of follow-up. So does 25-hydroxy-D status alter the disability trajectory? So our data from Health ABC showed that there was actually no difference in the rate of decline. However, if people start out having worse performance, then potentially they could cross this disability threshold earlier in life than those who have better performance and higher 25-hydroxy-D concentrations. We looked at this in Health ABC as well as CHS. I'm just showing the data from Health ABC here. And what we found was that those who had vitamin D insufficiency, whether you use a cut point of 20 or 30, had about a 30% greater increased risk of mobility limitations over 6 years of follow-up. Mobility limitations were measured every 6 months and were self-report of having difficulty walking a quarter mile or up a flight of stairs. Saw similar results in CHS, and that follow-up was only over 3 years. So observational studies are great for hypothesis generating, but as I think we've seen from the IOM report, it's really data from the randomized controlled trials that will really set guidelines. So do vitamin D supplements improve physical function? And again, what we find is that the results are inconsistent, with both showing no effect as well as improvements in muscle strength and physical performance. So this was a meta-analysis done a few years ago showing the effects of vitamin D supplementation on balance or body sway, the timed up and go, and lower extremity strength. And what they found is for both balance and the timed up and go, there was about a 20% improvement of those who were randomized to the vitamin D supplements compared to placebo. However, for muscle strength, there did not appear to be any difference between those in the vitamin D versus placebo groups. So in the largest trial to date, this was done in a subset of the Women's Health Initiative randomized controlled trial of calcium and vitamin D. Vitamin D supplementation was not beneficial in protecting against declines in physical function measured by performance or strength in older women over 7 years. Now, you will note that the dose of vitamin D was 400, and this was a secondary post hoc analysis done in the WHI study. So again, coming back to why are there so many inconsistencies among these randomized controlled trials? Many of the trials have very small sample sizes, less than 100 participants. Many trials probably used an insufficient vitamin D dose. Research from the Falls area has shown that it requires a dose of at least 800 IUs a day to prevent falls. And if you're thinking about the continuum of function, low function leading to falls, one would expect that probably 800 would be necessary for function also. The type of vitamin D, D3 versus D2. D2 has been shown to be less bioavailable, as well as the frequency of vitamin D supplementation, daily, weekly, monthly, annually. And there is some data, at least in the falls and fractures literature, to suggest that annual large doses may actually be harmful. However, we're always looking at a dosing strategy where people will actually be compliant. Many of the studies did not measure 25-hydroxy-D at baseline, so we don't know if the population was already vitamin D replete or not. And they didn't measure the response to vitamin D supplementation. So did people's 25-hydroxy vitamin D concentrations actually improve on the doses? There has been some reports of people having a resistance to vitamin D supplements and needing much higher doses to actually meet targets. Also, inadequate trial duration, sample heterogeneity, again, replete versus at-risk populations, community dwelling, nursing home, falls clinic. And then most of these are secondary outcomes in trials that were designed primarily to examine falls and fractures. So as far as the knowledge gaps and research priorities, what we've seen is that observational data suggests that 25-hydroxy-D concentrations greater than those for skeletal health may be optimal for non-skeletal health outcomes such as physical function. But is 25-hydroxy-D an appropriate biomarker? It's a prohormone, it's not the nutrient. And it varies by non-nutritive factors such as latitude, season, pollution, institutionalization, as well as nutritional and physiological factors, age, BMI and body composition, skin pigmentation, vitamin D binding protein, genetic factors. There's been suggestion that maybe the free or the bioavailable 25-hydroxy-D may be a better marker than total 25-hydroxy-D. How do these physiological factors such as age and BMI affect the 25-hydroxy-D response to dietary intake or endogenous production of vitamin D? Are similar associations observed in minorities? With the exception of the Health ABC cohort, most of these populations were predominantly white. In Health ABC, 40% of the participants were African American. We did not observe any differences between African Americans and whites when it came to physical function, but there has been a suggestion in the bone area that there might be differences. And then will increasing 25-hydroxy-D concentrations above the current IOM cut point of 20 improve physical function? So currently, there's a lack of convincing evidence for non-skeletal health outcomes, including physical function, from sufficiently powered randomized controlled trials. But I will say there are some large and moderate randomized controlled trials underway that have primary outcomes related to physical function. The Do Health study, which is a European study that Heike Bischoff-Ferrari is leading, has over 2,000 participants, and their primary outcome is functional limitations, functional decline, and they're also looking at physical performance and muscle mass as secondary outcomes. The Sturdy study is a dose-response study of vitamin D in falls led out of Johns Hopkins. We're currently doing a study called Evidence, looking specifically at people who are in that range of 20 to 30 and supplementing them to above 30 to see if there are further improvements in their physical performance. And then in the VITAL study, which is a very large study, a secondary outcome is disability. So as far as the implications for dietary guidance, current recommendations are based on skeletal health, the RDA of 600 for those under 70 and 800 for 70 and or for over 70. And this corresponds to 25-hydroxy-D concentrations of 20 nanograms per milliliter. Current vitamin D intake from dietary sources, though, is only about 200 IUs a day, so most older adults will not be able to meet the current RDA through diet alone. And then if randomized controlled trials show that vitamin D supplements or higher 25-hydroxy-D concentrations are beneficial or optimal for non-skeletal health outcomes such as physical function, higher vitamin D intakes will be needed, and this is likely to be in the range of 1,800 to 2,200 IUs per day. So probably not even 20% of the population will meet that need. So we would definitely need supplementation if we were going to meet that need. But I think currently the problem we're having is doing these randomized controlled trials in a setting where clinicians are measuring 25-hydroxy-D and prescribing pretty high doses of vitamin D supplements that have yet to be determined to be effective. Thank you.